Dear listeners, welcome to Faces of Digital Health, a podcast about digital health and how healthcare systems adopt technologies. I am your host, Tjasa Zajc, and this is the first part of a special 4-episode series about doctors who left full-time clinical practice to develop new solutions for healthcare improvement. As Faces of Digital Health is a podcast exploring global perspectives, you are going to hear from doctors from different countries, more specifically the US, UK and Spain. I've been noticing during this research that a lot of doctors going into entrepreneurship are trying to solve systemic issues plaguing healthcare. You will hear UK surgeon Owain Hughes explain how he started building a company and platform that connects GPs to specialists to enable GPs to refer patients more accurately. Consequently, patients can receive better care already on the primary care level, which makes the work of specialists much more efficient once patients reach them, making specialists and GPs much more satisfied with their work.
Specialists, we're just being honest and saying, what is actually in it for us to help our colleagues in the community. They've gone from that position, having started to use that technology, to be the biggest advocates. Because for the first time, it's allowed them to get control back of their work because they know how valuable their expertise is, and they don't want to waste time moving around the hospital or seeing patients in a setting that's not right for that patient. And now what they're able to do is direct patients to where they can be most efficient and manage that patient in the quickest time and the best time for the patient, but also for them as a service.
You will also hear a GI pediatric specialist, Michael Doctor from Boston's Children's Hospital, explain how he designed a task management app to enable better coordination of healthcare and administrative workers around all bureaucracy and care entailed in the treatment of every patient.
We often operate in silos in healthcare, and so how do we knock those silos down and work together and get on the same page? And that's not just internal teams, but that's, how does the healthcare system work better together to take patient care across the many stakeholders in the ecosystem? Could we be the platform that helps all those sort of disparate players work together for better patient care? That's our hope.
And from Spain, Guillem Serra. Guillem Serra is a serial entrepreneur coming from a family of doctors. And by that, I mean that his father, mother, grandfather and great-grandfather were doctors, which made it easy for Guillem to study medicine given his familiarity with the profession. Besides medicine, he studied math and during his medical studies discovered that for him, medical practice was actually boring.
Innovation, research, changing how we see medicine, how we can solve problems in medicine every day. The question is, you as a medical doctor, you see the same patients every day, you see the same problems every day. You cannot have time, for example, for innovation. You cannot have time for being with your patient actually today. So it was like, okay, you have 30 patients every day, different patients, same problems, same place, same career path. The everyday practice, it's not, you have to have a stomach for it to be, because it's not like you will have a great progression in terms of a professional path.
So Guillem went to found what is today called a WhatsApp healthcare app connecting doctors and patients in Spain, South and Latin America. More about that in the interview, which will be published in the upcoming weeks. So if you haven't yet, do subscribe to the podcast wherever you listen to your podcasts, so you will automatically be notified when the mentioned discussions will be published. Because today, we will start with someone many in digital health community would describe as one of the top authorities in digital health. Daniel Kraft is the founder and chair of Exponential Medicine, a program with the goal to unsilo thinking and unleash cross-disciplinary innovation across healthcare by bringing together thought leaders and forward-thinking clinicians and innovators to explore potentials to reshape health and medicine with technology. Daniel is a Stanford and Harvard-trained physician scientist, inventor and innovator with over 25 years of experience in clinical practice, biomedical research and healthcare innovation. We discussed his journey from the medical practice to digital health, his mission to turn his website digital.health into a medical digital health formulary where doctors could search for clinically approved and reliable digital health solutions to prescribe to their patients. Daniel also shared his view of COVID-19 related innovation, some broader societal problems that are arising in the US because of imposed measures to manage COVID-19. We also talked a bit more about how to improve medication adherence in patients with chronic conditions and comorbidities that take 5 or more different pills daily. The idea behind his company in telemedicine is to provide patients with a device that would keep all medications of a patient in separate cartridges and would produce only one pill the patient would need to take. The pill structure would be based on the patient's daily various health measurements supported by AI analysis. A lot of exciting topics, so enjoy the discussion and find the recap of the show on our website www.facesofdigitalhealth.com. The direct link to this episode is in the show notes, as is the link to digital.health and Exponential Medicine's website. Okay, so Daniel, you're very well known in the digital health community as the founder and chair of Exponential Medicine, which is a special healthcare innovation program running under Singularity University. However, you actually have 25 years of experience in clinical practice. So what year did you actually stop working actively in clinical practice?
Well, I'm still licensed as a doctor, boarded up in internal medicine pediatrics. I did fellowships in hem-onc. Until a few years ago, I was doing attending at UCSF in pediatric bone marrow transplant, which is sort of my specialty area. It's hard, and then I got so busy with things at Singular University, Exponential Medicine, startups. It's hard to do these 3 or 4 week blocks on service, but I still like to do some volunteer elements. In the past, I've done a fair amount of international medical work from Nepal to Nicaragua. So I think it's important for all of us who are trying to innovate in the clinical space to keep a touch point in the clinical world as well, not just prescribing our friends and family azithromycin or to the president hydrochloroquine.
I agree. You did, to a certain extent, ruin my next question on a scale of 1 to 10, to which extent you don't miss dealing with electronic healthcare records.
Well, I grew up in the era at the transition. So when I was a medical student and resident at Mass General, we still used to handwrite our notes and pen and paper. I was one of the very early adopters. I had the Hewlett-Packard 200LX little pocket computer, and I would sometimes type my notes on that and print them out and put them in the paper chart. And then when I was a fellow at Stanford, there was a bit of a transition to Cerner and later Epic, which are, there's something just beautiful about being able to open the old-fashioned analog book and look back at who wrote the orders in their handwriting. So I don't necessarily miss all the focus now on computer time and documentation that really is taken away, I think, well described, from the joy of medicine and even the important elements, which is the human side, and actually not just the billing, which is really what the electronic medical records are built on. They're not really based for care. They're based on records and billing codes. I don't miss that component at all. And I think I use the word epic fail that the entire electronic health record industry has sort of instilled, in that it's sort of at cross purposes with what we really want to be doing, which is real care, not just electronics.
What are your initial memories of that transition when computers started to be used more regularly? What frustrated you most? What kind of problems do you see that are still most present in the current clinical practice? Because especially in the US, we already see many innovative approaches, from using voice technology supported with AI to take those notes and using either screens in the doctor's room so the doctor has the connection with the patient. What's your experience of that first contact with technology and how it then evolved?
Well, I think we can think of it in different ways. When I was a resident at Mass General, and I started out with this little sort of book of, how to admit and rule out myocardial infarction patient with sort of rules of thumb, because we'd handwrite all our orders. Now you can sort of press a button, hit the rule out MI order set or diabetic ketoacidosis. So the sort of old school piece, when you go from your brain to your hand to writing the orders, gave you a whole different context about what you're doing, kind of a time to think, to adjust. By the end of my residency, we had more of these sort of printed out protocols. Here's the rollout MI protocol, and you sort of check the boxes. And that's been, amplified up even more in the digital age when you can cut and paste the medical history. You can sort of cut and paste into different order sets. And I think there might be something lost in the ability to cognify, think a little more deeply. And often takes, sometimes better and sometimes worse, some of the autonomy from the clinician who now might be uber measured. Wow, you deviated from the quote unquote protocol for 10% of your patients. Maybe that was a really smart deviation that really matched what that patient needs. Maybe it didn't fit within the cost constraints of that hospital. You prescribed a drug that wasn't the lowest cost on the formulary. So I think there's a plus and minus to all this. We can, in some ways, better standardize some elements of healthcare where there's real data that really informs where things can go. But at the same time, it can be a bit of a flip side to over protocolizing things.
You just reminded me of an article that said that all this copy pasting actually causes that the doctor in the end, when he looks at the patient notes, might forget completely what he really thought about that patient. Or as Eric Topol mentioned about abbreviations that are used within normal limits actually can mean we didn't even look at something.
Yeah. WNL or SOB doesn't mean just shortness of breath in some certain contexts. So that, there is something about, again, that hand to brain to paper piece that has some power. I mean, I think it's been studied when a medical student or whatever writes notes. I remember studying for MCATs and things with cue cards and medical boards. That would wire your brain differently than when you just type notes on your laptop or watch a video rather than being in the class or having a real-time contextual discussion. So I think people learn differently. I think some of these digital tools can be optimized, and we can learn how we learn. And again, that can be personalized, just like personalized medicine. It's not one size fits all, but there's definitely, I think, potential challenges in our sort of digital age where things can be too dumbed down. Yes, we can be upskilled, but if we simplify things too much, everyone, the potential is really to pull down the individual's patient's omics, digital exhaust information, sociome, genome, microbiome, and then hopefully use some of the digital layers to put that into context. So we really have actionable information that can really make a difference without overwhelming the clinician or the healthcare system, and also aligning how we want to care for folks in the immediate and long term.
How far do you think we are with that, creating, as you called it in one of your speeches, the Digitome?
Well, we're sort of already there. I mean, but just put it in context, it was only 2009, 11 years ago that the first Fitbit came out, right? That was sort of maybe one of the earliest connected devices, did very basic steps in sleep. Now we have, thousands of different sort of connected wearables and now insidables and breathables and even things that you don't need to wear. You're connected to Wi-Fi, and voice can give you our digital exhaust. So I think we're sort of already there in that era of digital exhaust now being integrated. I mean, the fact that on my Apple iPhone, I have the health kit data, and I can integrate things from my scale, my blood pressure cuff, if I use that, if I had a glucometer, my heart rate data over time. So, when it comes off my watch or an EKG, so we're now able to integrate the data more readily. It often still lives on our siloed smart devices, but we're starting to move from quantified self, where you have that as an individual patient, to quantified health, where it can flow to your medical record. What happens when it gets to your medical record is a second question. But all that potential is really here now. So we have the opportunity to go from quantified self to quantified health and really use that in a much smarter way to be much more proactive, real-time, continuous, to optimize prevention and wellness and health span and align the incentives for that, to optimize early diagnostics. There's a lot of work now in the era of COVID, just using your Fitbit or your Apple Watch to pick up the signs of someone 2 or 3 days before they become symptomatic with COVID, so we can identify and hopefully quarantine, and maybe even when drugs are available that are preventative or slow the course, give that early rather than late. And then on the therapeutic side, now all these new tools for remote patient monitoring, whether it's your your wearable counting your steps after a hip surgery and seeing if you're doing better or worse, all the way to, connected blood pressure cuffs and beyond that can really inform the feedback loop. So we're already there. The trick is some great solutions are out there. How do we really connect the dots, align incentives, and get these things utilized, particularly mindful of the workflow of the clinician who does not want to see every piece of data. They want the meaning from that. They want my view of the future of healthcare is if you're a primary care doctor, you have 2,000 patients, you don't want to wait for them to show up, with a problem in the ER at 2 a.m. You want to have a dashboard of your 2,000 patients with those who are in the green, those who are in the yellow, who might have their blood pressures out of whack or haven't been taking their meds or are showing signs of relapsing in some form. And then those in the red, you really, make sure you're proactive and act upon. And hopefully that's aligned with the incentives for, keeping them out of the hospital and giving them better outcomes.
Since you mentioned COVID, there's actually 204 products currently being developed or tested to battle COVID, either vaccine or as a treatment. So in that regard and in everything that you mentioned, how do you think the digital revolution or all the data and AI capabilities that are now being developed, how can that be used in figuring out how these 204 identified potential solutions can be successful or not?
We have the ability and need to use these connected tools, whether it's not even connected, but a pulse oximeter or someone's wearable data, to use that in doing early triage, finding folks who are sick, if they happen to even been positive or not even tested, to track their data, their respiratory rate, their oxygen saturation, understand when they might need to come into the hospital or not. And so while there's a lot of innovations coming up, some of them may be related to, again, listening to your cough and maybe diagnosing COVID based on the sounds of your breath or your voice, new ways to track respiratory status. I think there's tremendous need, and what's being catalyzed in this era are a lot of new solutions, and hopefully we can use digital trials and new ways of collecting data to find the ones that are really working well and then distribute those. We don't need 1,000 COVID apps. We need 2 or 3 that really work in a connected, integrated way.
Yeah, I guess people use various apps. There's definitely a wave of options on the market, but personally, I looked at the Apple's application and what WHO was putting out there, because you want to have reliable information and solutions.
So you're talking about, for example, Apple with the CDC put out a COVID symptom checker, which can be helpful in helping folks triage themselves. Do they have symptoms consistent with COVID, which in the early days was just, cough, fever, and shortness of breath. Now we know, partly through digital health and collecting data from thousands of folks, that loss of sense of smell and taste and extreme fatigue and even diarrhea and other symptoms can be emblematic of COVID. It's not just the classic few elements. And so these sort of triage type tools are relatively basic, but can give smart guidance and hopefully help healthcare systems not be overwhelmed at the same time. I'm actually working on a project right now with a volunteer team to build an app for the WHO, which I sort of thematically think of, and as I pitched it to them, would be a bit of a Waze for COVID. Because when you're getting information about COVID, you want to know it based on your zip code and the right language, potentially eventually give you the testing sites and hospitals that are available around you, and how prevalent is the disease in your neighborhood, and guidance that's related to your country or state. So we're building up the basics of that, which will hopefully be impactful. Information is super important in this pandemic. It's also an infodemic. We have a lot of misinformation out there, whether it's about drugs that are unproven, like hydroxychloroquine, or the anti-vax movement getting into the mix now. And I think it's going to be a huge challenge when drugs and validated vaccines are available, that in many cases they may not be used based on political or other leanings.
So the solutions that you mentioned that you are helping develop for WHO, that's meant as a global solution, so it's going to be adapted based on the country, or is it more US focused?
The plan is to, many countries don't have their own apps or a CDC type platform. That this is we're still waiting for official approvals, and we have a very smart tech team building things out based on what the WHO needs and wants. But the idea is that it would be very hyper-local, in the official languages of the WHO, which is, I think, 9, plus many others. And with eventually very hyper-local information, partnering with things like Google Maps, which is now putting in testing sites, et cetera, to having potentially symptom checker type technologies, which are relevant to that setting. It's very different if you're doing a symptom checker in a refugee camp and you don't have the ability to sort of shelter in place and have physical isolation, or if you're in a more developed setting. So my hope is, whether through the WHO or others, we'll have more and more smarter, more hyper-personalized tools for COVID-related information, and then what to do about them. Because as you know, in the digital health space, there are thousands and tens of thousands of quote-unquote digital health apps, some of which are now FDA regulated for managing diabetes or mental health, for example, others that are more on the wellness side of the equation. I think what's going to be interesting is, how do we start to have a bit of a way of selecting those and personalizing those? For example, a digital health formulary. So one of my early projects that I recently launched is a website called digital.health. It's literally their domain, digital.health. And my view and vision for that is to become a powerful digital health formulary. So if you're a clinician seeing a patient with diabetes and hypertension and smoking and depression, you can find the wearables that might help them manage their atrial fibrillation, but also an app to help them with their smoking cessation or their mindfulness training to help their depression. So we can start to prescribe tools, apps, solutions, wearables, etc. Those hopefully can be paid for by different payers when it's appropriate, and then the data can flow back in a meaningful, useful way to the clinical teams and to the patients themselves.
I've been hearing from some doctors that are in the digital space that among their peers, there's actually not so much knowledge about, all the possibilities that are discussed in digital health space. So if you're active in the digital health space and if you continuously meet doctorpreneurs and innovators in medicine, you may quickly get an impression that the whole healthcare space is super interested in progress. But some data or people suggest that it's actually not like that. So from that perspective, how do you tackle onboarding of all the doctors to go to a site like digital.health and leverage from all the knowledge that's already been proven to be useful?
I mean, we live and breathe this sort of space. And I often give, keynotes when we still used to travel and go to real keynotes or even online ones, how many folks who are in the middle of pharma and med tech and devices and hospital systems have no clue what's here, let alone what's coming. I mean, my friend Dave Albert invented the AliveCore EKG. It's amazing now. You see them on CNN on advertisements now, but still many cardiologists and primary care docs don't even know about an example of an early successful digital health product and a device that you can put on your phone or carry around that can do a full-on now 6-lead EKG. Wouldn't you want to prescribe that to your patients who have atrial fibrillation? So when they call you at 2 a.m. with feeling fluttering in their chest or something, you can actually capture that data or use it for triage when someone walks into your office for urgent care. But many folks just have no clue that there's a whole new sets of tools and technologies available now, let alone, again, the future. So I think that's part of what I want to do through digital.health is if you log in and you're a pulmonologist or a psychiatrist or a neurosurgeon, you can have a very different set of tools and solutions that have been vetted and are hopefully, when relevant, FDA or cleared or CE marked, et cetera, that you can use again as a smart formula. Just like when you're trying to pick the right antibiotic for a patient, you'll base it on their age, their weight, their renal function, the antibiotic sensitivities, et cetera. But I think we have a ways to go to help clinicians and align the incentives, because one of the folks, even if you're a cardiologist, you don't want to get the EKG, every EKG from your patient. You might feel liable for that. What if I missed a funny arrhythmia? Who's owning that data? Who, again, might be in trouble for not using it? So it may not always be obvious that some of these digital health tools, which have tremendous potential, don't fit in with often the workflow or the incentives of often busy and overwhelmed clinicians who don't want another app or platform to have to log into.
I want to address also some of the inventions in your portfolio, if I may say so. So in 2018, you presented your company IntelliMed on the TED stage. And if I try to sum up the idea, it's to have all medications of a patient in cartridges, and based on the daily measurements supported by AI analysis, a machine would then produce one pill that the patient would take that day instead of 5 or 10 that an older patient with chronic conditions and comorbidities needs to take. That's obviously an inspiring idea, but I'm wondering, so how far is the development? You started developing this already 10 years ago. In 2011, there was the first request for the patent, which was approved last year, right?
Yeah, you're way ahead of me. Good summary. I think in general, I like to look at healthcare and healthcare innovations from the pain point, or what's the problem we're looking at. And so a big challenge across healthcare in general is adherence or low compliance, meaning patients take a pile of pills. Many older patients especially have a lot of comorbidities. They're taking aspirin, statin, beta blocker, 2 other hypertension meds, maybe a vitamin D. And so we have polypharmacy, and folks have a problem. 50% of medications aren't taken as prescribed, partly because often there's too many meds, and then they're not adjusted to the individual, based on their weight or renal function or eventually pharmacogenomics. So the idea around telemedicine is not to print all your medications, but let's start with the common generics that are for very common diseases like diabetes, hypertension, cardiovascular disease in general. And so that we can ideally give you all 3 of your blood pressure meds in one that is adapted to your needs and your side effect profile and your blood pressure itself. So that was the initial idea that I had 10 years ago, filed the IP, which finally issued. As you saw my TED Talk, we have our sort of prototype printer that's sort of the kind that you might have in a corner pharmacy, that maybe you could do a pill every second. We've now built a smaller prototype of one that might be eventually in the home. So you get a little cartridge of the 5 or 10 meds you're on. It would blend the medications that you need based on your digital data. It might be your blood pressure, it might be your mood, it might be a blood level. So now we're in the process of building next generation devices, and hopefully we'll get something into a clinical setting and show that again, starting with something as common as hypertension, this could be effective and lower costs and improve outcomes and make, again, healthcare much more tailored and feedback loop driven.
What is the regulatory side of such a solution? Every medication needs to go through rigorous clinical trials. I mean, how rigorous are clinical trials going to be in the future might be quite tested with the COVID-19 vaccine development. New York Times revealed that if the vaccine would be developed in a normal way, it would be on the market, I think, in 2036. And we're talking about having it in a year. So I'm sure some things might change after this pandemic ends. But in your case, so creating a personalized pill, how do you test that if each pill is different for each patient because it's personalized?
In a sense, we're not reinventing the drugs at all. We're starting with very common generics that have been used for often decades. So, and it's really, when you take your pile of pills together, you don't need to do a trial to say, there's certainly obviously some rules and guidelines. You don't take a beta blocker with an alpha agonist or whatever it might be. And, but essentially we're already taking multiple medications together. The trick, essentially also the practice of medicine and pharmacy is compounding. You're able to, in the practice of medicine in most countries and states, blend medicines together with mortar and pestle and put it into a single capsule. That's the practice of compounding. So essentially in telemedicine is really automated, roboticized, personalized compounding, where we're going to blend already approved medications that are able to be taken together into a single capsule, and that can be adjusted. So you don't need to do a trial if that personalized medication is built specifically for you, and not putting it on the shelf as a combination hypertensive drug that can be taken that's manufacturing. But again, in telemedicine is really the sort of future, I think, of personalized compounding, starting with existing already approved drugs, where you can never do a clinical trial for every single combination, every single dose. That's not realistic, but we would know that these drugs have already been taken together, and hopefully then we can match and optimize the doses, which in the end, I'm quite confident will lower side effects. Thousands and potentially more patients die every year for adverse drug reactions because they may be on the wrong dose or the wrong combination. And it's not just about quote unquote printing the combination medication. I think we have the need to use our new tools of AI, machine learning, omics, et cetera. Even the microbiome can affect what drugs work, what drug dose is effective, to help pick the right combination and doses of medications as well, not just the drugs themselves.
One thought that I also had when I was thinking about this is just the fact that there's still some unknown side effects when you combine the drugs. We know about the drug-to-drug interactions, but we don't still know about potential interactions or side effects that come from combinations of drugs. If I try to be a little bit more specific, in 2015, Russ Altman had a TED Talk where he explained how glucose changing signals showed up with the big data analysis for people taking antidepressants and cholesterol medicine, and that was not known before that. So, from that perspective and from the fact that we still might not know what a combination of drugs might do, and on top of that, knowing that new medications are already cocktails of drugs. So how do you ensure that you're going to have a useful pill that's printed, let's say for a patient that's diabetic with AFib, high blood pressure, high cholesterol, potentially insomnia, it's taking painkillers because he has a headache, and gets a cancer diagnosis with potentially an immunotherapy or a genetic therapy?
Great question. Number one, we need to learn better about the real world of patients taking medications. Most trials are done in very narrow, limited ways. You cannot have a patient who's obese or has renal disease or has cancer or other comorbidities. So a lot of these drugs are trialed and approved on very narrow criteria, not quote unquote the real world examples. And as Russ and others have shown, you can learn that certain drugs in the context of folks taking, osteopenia med or antidepressant can have untoward potential side effects. So I think, outside of the context of even in telemedicine, whether you're printing your medicines or not, we can start to now crowdsource a lot of this data using hopefully unsiloed EMR data and interoperability to really learn that at scale. And hopefully what we'll learn is, whether it's through this telemedicine platform or others, what doses and combinations in the real world are impactful. And when we can collect that real world data, whether that's side effect profiles, other physiologies, blood levels, we can then take that kind of crowdsourced information and use that to better build the algorithms that choose the ink, what we print or the medications we print, whether it's in a printed pill or the pills that you take in general. And back to even the era of COVID, it may need, just like an HIV, a cocktail of drugs that match, because we know the issues of drugs incurring resistance. We often need, as we learned in HIV, a cocktail. And many of the successful drugs, there are cocktails, heart therapy. And so it may be the future of COVID will be needing to take that sort of cocktail, and that might need to be tuned very specifically to that patient's age, weight, renal function, pharmacogenomics, et cetera. And so I think the future of medicine can be much brighter when we do share all this information across the silos of pharma and academia and hospital systems and PBMs, so that we can collect that data in almost real time and then have that translate to real world actionability.
The whole field of medications and the pharma industry is definitely very, very complicated. Apart from taking into account everything that we discussed, there's also routes of administration. So do you think it will ever be possible to combine medication that needs to be given subcutaneously, intravenously, a rectal medication, an oral medication, or we could go on with what kind of options we have when we're talking about medications?
I mean, clearly, there's a lot of work to try and make what used to be an IV drug oral. There's a really interesting company here in the San Francisco Bay Area that has almost a robotic pill. This is for drugs that normally are biologics and need to be given IV or subcutaneously. It's called RANI, R-A-N-I, and they built a little pill that you ingest, and when it's in the right part of the gut based on pH, it basically has little spikes that come out and inject the biologic drug into the gut wall, where it can be ingested, and that will avoid someone having to go and get an IV infusion in the outpatient or the clinic setting. So I think we're going to see a lot of blending. Patches have been looked at. You might imagine the future of drug therapy, maybe it's hypertension or mental health, is in a connected patch that looks at your data and releases drugs at the right time based on a whole set of parameters. we have a sliding scale for insulin, but that's basically it for most drugs. I think we'll hopefully see that kind of connected ability to really deliver the drug, whether it's through an implanted device. Electricity as medicine is another approach too, neuroelectrics.
Music can also be a medicine.
Sure. There's companies like BioBeats and others where you can use music to help people's brains and focus, all the way to helping in rehab from COPD to CHF to diabetes, getting folks to move, to get engaged. The impact of our mental health on our physical health is all tied together. And part of the potential of digital connected mobile health is to sort of be more holistic and connect those dots rather than the usual siloed drug, that often use word beyond the pill. You need to have that sort of digital wrapper around that, which might tie not just to the molecule itself, but all the other elements in that individual's life, ranging from their diet to their social interactions.
Going a little bit back to the basics of what IntelliMed is trying to achieve, which is make it easier for patients that are taking maybe 5 to 10 drugs to adhere to the therapies that are prescribed to them. I can say from my own experience in the past, when I had to take that amount of medications, I actually had a notebook where I wrote all the medications and just ticked what I took, because if I didn't, by the time I came to pill number 5, I wasn't sure anymore what I've already taken and what I still have to take. So the idea of having a printer that would print out one pill is absolutely inspiring. But do you think it's possible that it would turn out in the end that it's impossible to come to a solution like IntelliMed, similarly as Theranos had an amazing idea, but it turned out in the end that many professionals said that it's not biologically possible to achieve that kind of a solution?
Well, Theranos is a totally different issue. I mean, they were basically faking their data technology. I think if we're talking about telemedicine, we start simple. We're starting with common generic drugs, ACE inhibitors, beta blockers, calcium channel blockers for hypertension. Might be your baby aspirin. It might be your statin. It might be a little bit of vitamin D or CoQ10 if you need that. So these are medicines that have been taken for decades safely, that we're already combining in millions of patients. We're just making it an easier form factor and the ability, when it's relevant, to adjust the dosing. And if you saw the TED Talk on the technology, it's pretty straightforward. We're sorting, I call them micromeds, 1 or 2 milligrams each. So it's not a magical leap. And speaking of Theranos, the promise of what they pitched, 10 plus 20, 10, 15 years ago, even now, is now reality. There's several groups which unfortunately have been harmed by their Theranos debacle that can do labs on a chip or use your smartphone camera for diagnostics. I'm on the board of a company called Healthy.io out of Israel. They use your smartphone camera to take a picture of your urine dipstick and now can do detailed urinalysis or pick up protein in your urine. They're also using the smartphone camera to analyze, wounds in a wound care type setting when a visiting nurse comes in. So there's lots of new ways that is bringing, diagnostics from the lab setting to the home that are now being proven out. And the challenge is to connect the incentives, how we pay for things, who adopts them, getting into the workflow of the nurse, the doc, the pharmacist. That's often the harder barrier.
How fast do you think the solution could be available on the market? The old saying was that any new healthcare innovation takes around 15 years to become a standard in clinical practice. Do you see any changes in that time span with big data and, AI?
I mean, we're seeing already in our era of COVID, just in the last 3 months, the acceleration of telehealth, the acceleration of certain approaches, even just learning, like what was learned in Wuhan, China, and in Italy in the ICU units, quickly translated to being utilized in New York City, and learnings there transmitted to other places. So we're hopefully catalyzing and speeding up the pathway of learning, and it's not waiting 18 years from publication to standard of care. And that's going to apply to, especially to digital health related solutions, not necessarily always in molecules. We're seeing the speeding up, obviously, in vaccines. And there's a downside to that too. I mean, there have been definitely vaccines that have been developed for things like dengue fever that had antibody dependent reactions where you could have a worse outcome if the strain changes or the immune system takes off in the wrong way. So I know we're all in a rush to get a COVID vaccine and other therapeutics, but we do need to be mindful that, you can't make a baby with 9 women in 1 month. Some things still take the time to look at the downstream course. But I'm very confident that particularly in our now uber connected digital big data age, we can accelerate, learnings, trials that can be increasingly done at home. And when those things are well proven, distribute those to impact in a faster way, because it has been sometimes intrinsically very slow.
Because you are one of the healthcare leaders that are following all the technological progress most closely, is there anything that you can mention that you are most optimistic about in, let's say, the short run when it comes to healthcare? Maybe this can also be a comment on how healthcare around the world has changed, as they say, more in a month or two when COVID hit than it did in the last 20 years.
So one of the things I'm most excited about, I think that's emerged in this COVID era and has been accelerated, is now connecting of the dots, remote patient monitoring, which even started to get reimbursed in the last year or so under a setting of Medicare in the United States. And now you can have a connected sensor pick up respiratory status, and that might be relevant in COPD, but also in somebody who's diagnosed with COVID, or a connected pulse oximeter, and potentially use that to monitor a patient and triage them appropriately. So I think that's sort of that now blend going beyond telemedicine, meaning where I can see you on the screen, you can see me, we have some chit chat. I'm going to hopefully have much more contextual information, that asynchronous data, meaning the data collected from my smartwatch and smart home and digital scale and blood pressure cuff, can hopefully inform that connected care visit, so that you're not just popping up on the screen, but I know what that patient's context have been, what's with their resting heart rate, what their temperatures might have been, what's happened to their weight, have they been taking their medications or not. So all that, some of those dots are starting to connect. Still a long way to go, but that's one of the things I think is a bit of a positive coming out of this, major crisis.
Are you, as a doctor, worried about reopening states in the US too soon?
Absolutely. I think, it's not just about reopening, but we have some folks maybe driven by ideological things that are going and having big parties and going back to bars like nothing happened and not wearing masks, or assaulting people who do. There's lots of different mindsets based on where you are and even political parties. So there's a real danger about this, not just this this political divide and this infodemic I mentioned earlier, where there's misaligned interests at play. I think I'm concerned we are, yes, opening up too early. We still have in many states no downward trend, but we're opening up the beaches and bars and tanning salons and tattoo parlors. And I totally understand there's a need to open up the economy at the same time in smart ways, but I think it can go and it's going to boomerang and bite us in certain places, which will hurt the economy and the recovery if we opened up too soon in the wrong way and without some of the proper testing available, because we still are behind in the US especially on the ability to get rapid testing, both for acute disease and then on folks who might show recovery from antibody-based immune testing.
Okay, so that's kind of a depressing ending.
Well, I would also say, let me be more optimistic that digital health, which we're talking about here, vaccine development, new forms of doing creative clinical care. I found a slide the other day on Twitter. The summary is, who led the digital transformation of your company? A, the CEO, B, the CTO, or C, COVID-19? So there's that Chinese proverb about crisis also being the same word as opportunity. It's a big opportunity to catalyze positive changes and to illuminate some of the big gaping challenges like social disparities and ways healthcare systems and supply chains haven't worked. So that crisis creates opportunity now to collaborate in new ways. I haven't seen so much collaboration happening in new international and cross industry ways ever. I'm chairing the X Prize's Pandemic Alliance Task Force, and we have 60 plus organizations from NGOs and academics to big companies to startups, all collaborating together to find commonalities and find challenge areas or ways to meet needs in smarter, better ways. So I think there's a lot of good things that are going to come out of this. That's a bit of the silver lining. And hopefully we build a better, smarter public health system around the world that can prevent the next pandemic. An idea that I have along with my med school roommate and colleague, Lee Sanders, who's the chair of pediatrics at Stanford, is could we have a kind of global health corps, volunteers, just like EMT, ambulance drivers and firemen volunteers in many towns. You don't have a professional firehouse. You have folks who are volunteers. They show up when the bell rings. Could we train folks up, just like we train people in CPR, train them in basic contact tracing, which is starting to happen, but give them digital tools and others to upskill them, community health workers, not just to do contact tracing and help triage in the setting of a pandemic or an epidemic, but to be addressing social determinants and disparities in smarter ways. And that could be a powerful potential platform around the world to prevent the next pandemics, but also address public health and other elements at their base.
Just one last question for the fans of exponential medicine. I assume there is a chance that the live event or gathering is not going to happen this year in November. Do you already have any plans in that regard, or do you still hope that maybe by some miracle it could happen?
I'd like to believe in miracles, but I don't think anyone's going to be, even if we have a vaccine next month, that we won't have it distributed well. People aren't going to be back to traveling. Many healthcare companies, hospital systems have been devastated. I think it's going to be a bit of a slow restart, particularly around healthcare. I mean, we've lost, I think, $50 billion across hospitals just in the United States. But I do plan to have some sort of online virtualized event. And there's many new ways to make those much more engaging than just being on Zoom. So watch the space. You can follow me at danielcraftmd.net and on Twitter at Daniel_Craft. And we'll have some new form of exponential medicine or a new rebirth of how do we really bring together leading clinicians, innovators, technologists, investors, patients, nurses, healthcare systems to really think about what's next in healthcare. How do we catalyze the future of health and medicine, not just in digital, but across the whole spectrum, because we really need that kind of convergence now to address this pandemic, but also other major challenges that are global.
You've been listening to Faces of Digital Health. If you liked the show, do leave a rating or a review wherever you get your podcast. This is the fuel for the show and helps others interested in digital health find the show as well. To browse through past episodes and find more about the podcast, go to www.facesofdigitalhealth.com. And of course, stay tuned.